Hello and welcome back. I'll be discussing part 1.1 in an approach to vomiting and abdominal pain. So today we'll be talking about an approach to localized significant abdominal pain with or without vomiting. So what I'll be discussing in this topic will be we'll try to deduce the causes of significant focal or localized abdominal pain with or without vomiting. In that, we'll compare and contrast between five main causes of vomiting uh, or localized abdominal pain with or without vomiting. I'll talk about some caveats in the evaluation of focal or localized abdominal pain in internal medicine and particularly understand how parietal peritoneal involvement affects pain localization in these situations. We'll try to understand how radiation of pain affects pain localization in these situations. We'll discuss two systemic causes of abdominal pain that mimic causes of focal or localized abdominal pain and how to evaluate patients with those suspected causes. We'll discuss situations in which cholecystitis is the result of systemic disorders. In particular, we'll be talking about how acalculous cholecystitis occurs in vasculitis. Then we'll try to understand what exactly is dyspepsia and how that relates to abdominal pain. And under that, we'll try to deduce the possible causes of dyspepsia. And then we'll try to enumerate the possible underlying etiologies of dyspepsia. And finally, we'll try to understand the what we mean by the term functional dyspepsia. And that will bring us to the end of this discussion on an approach to abdominal pain and vomiting, a general approach. And then we'll, in the subsequent videos in this lecture series, we'll go ahead and talk about the individual etiologies. So starting off, obviously we've already discussed, we've discussed diffuse abdominal pain with or without vomiting and poorly localized abdominal pain, which is significant with or without vomiting, and we'll discuss why that happens. But now we'll get to what is usually the domain of the surgeon, that is significant focal localized intra-abdominal pain with or without vomiting. However, there are certain situations in which the primary disorder is that of related to internal medicine and therefore requires immediate identification and evaluation from our side. So we'll talk about that. Okay, so now the thing is that significant focal or localized intra-abdominal pain can with or without obviously abdominal or vomiting can be due to either pain that has been referred. Yeah, so it could be due to referred pain originating from a structure, extra-abdominal structure that is near the abdomen, or it could be from true pain originating within from an intra-abdominal structure itself. So first we'll talk about referred pain. So due to referred pain originating from an extra-abdominal structure. Now, when we talk about referred pain, we need to understand what are the structures that are nearby. So what all do we have? We have the heart. We have the parietal pleura right next to the right upper and left upper abdomen. We have the esophagus, which is present retrosternally. We have the spinal cord posteriorly, and obviously the nerves supplying the abdominal wall and the chest wall, arising from the spinal cord itself. So these are the structures from which you can technically get a you can get a referred pain. Now, abdominal aorta is an intra-abdominal structure, but it's retroperitoneal. So even though it is not strictly speaking, referred pain into the abdomen, I'll be I'll be discussing it along with the other causes of focal abdominal pain because again, these constitute emergency situations in which um, the call on whether or not to do manage surgically or to evaluate needs to be taken in the ER. So they require to be discussed together due to their clinical presentations. Okay, so moving ahead. So these are the structures from which you could get referred pain into the abdomen. Now, so like I've said earlier, we'll divide the causes based on whether or not you could have vomiting along with it. Or vomiting, obviously, in this situation would be due to activation of the vagus. Okay, the vagus does not supply the abdominal wall or the spinal cord, so as a result, you will not get vomiting in cases where the pain is referred from there. But yes, it does supply the heart, various parts of the pulmonary architecture and the esophagus. So as a result, you can get vomiting in those situations. So when I talk about cardiac disorders, any type of cardiac inflammation, that could be pericardial, myocardial, particularly myocarditis, okay, or acute coronary syndrome. Very rarely chronic stable angina, but that's why I put it in red. But yeah, it can technically be a cause. But if you are attributing it to chronic stable angina, it would be prudent to look at other causes as well in that patient. Then endocardial disorders, but very rarely. Okay, it's not a common thing with endocardial disorders. Then we have esophageal disorders. So esophageal disorders that can cause abdominal pain obviously would be localized to the lower esophagus. So structural disorders of the lower esophagus, like esophagitis in that area, and rupture of the esophagus can technically present with abdominal pain that has been referred from the esophagus into the abdomen. Now, they could have functional disorders of the esophagus, particularly diffuse esophageal spasm. So diffuse DES stands for diffuse esophageal spasm. Okay, so these are the disorders that you could technically have as the causes of abdominal pain. Then we have pulmonary disorders that will include pleural disorders. That would obviously be pleuritis, epimyem, pneumothorax, parenchymal disorders with secondary involvement of the pleura, so lower lobe pneumonia, and pulmonary vascular disorders. Most importantly, obviously, pulmonary embolism. Okay, so these are the disorders that can get referred into the abdomen and mimic the presence of focal or localized abdominal pain. And because these structures are all supplied by the vagus, in addition to the fact that the pain is referred into the abdomen, you would also get vomiting. So these would be false localizing signs that lead you astray into a diagnosis of pain arising from somewhere within the abdomen, when actually the pathology lies elsewhere. Now, when it comes to the spinal cord disorders, with or without radiculopathy, cause something called funicular pain. So that is a band-like sensation that you feel over a particular level of the abdomen or the thorax. So that can technically, also mimic focal abdominal pain. But often, if the history is detailed, that confusion does not arise. Then you could have polyradiculopathy. Again, that would cause a type of focal abdominal pain, and peripheral nerve disorders, very specifically herpes, causalgia, and tabes dorsalis. Also, we don't get tabes dorsalis. That is a complication of syphilis that we don't get anymore. Then we have abdominal migraine. Now, one very important caveat about abdominal migraine is abdominal migraine does not occur in adults, or it has at least not been described in adults, unless the patient has had a history of abdominal migraine since childhood. It is a disease that starts in infancy. So do not diagnose abdominal migraine in a patient who does not have a history of childhood episodes of abdominal pain and episodic abdominal pain associated with other migrainous symptoms. Okay. Then we have abdominal wall disorders. Now, there are essentially any part of the abdominal wall can be affected. Okay. But one disorder that is most important to consider is chronic anterior cutaneous nerve entrapment. Okay. So anterior cutaneous nerve entrapment occurs on the lateral border of your this thing, the what is that called? The this thing, abdominis. So as it goes via that fascia, it gets entrapped there, and it is a very specific finding. You apply pressure there, the patient has pain, and again, it's very benign. It does not require any evaluation, so it's always prudent to consider it prior to a detailed evaluation for this. And obviously, it will not come with an acute abdominal pain. It will be more of a chronic problem, so it will not usually necessitate further evaluation. Okay. Now, significant focal or localized intra-abdominal pain can, without vomiting, can also arise due to pain originating from intra-abdominal structures. So these intra-abdominal structures, there are four pathologies that we need to discuss specifically. One is the peritonitis, and specifically, obviously, because it is the parietal peritoneum that is supplied by somatic nerves. Um, Therefore, it is parietal peritonitis that we're talking about. Uh, Second, we'll be talking about distension of hollow viscus. Now, hollow viscus could be the gastrointestinal tract, it could be the extrahepatic biliary tract, it could be the ureter. These are the three hollow structures within the abdomen. It could be due to acute mesenteric ischemia. It could be due to distension of visceral organs, and it could be due to acute pancreatitis. So we'll be discussing peritonitis superficially because again the source of peritonitis is what matters. So I will talk about how that determines the rate of progression of disease. Um, in case of hollow viscous related pain, it can obviously be intestinal, it could be biliary, and could be ureteric, as I've just discussed. Then we have acute mesenteric ischemia. We'll be discussing this in detail. But generally speaking, it could be thrombotic occlusion of vessels. It could be embolization, cardiac embolization, or artery to artery embolization. It could be vasculitis. And in specific patients, it could be sickle cell anemia. So we'll be discussing this in detail subsequently. Then we'll talk about the distension of visceral organs. Now, the important thing is that the visceral organs themselves per se are not sensitive to pain. It is their capsules that are sensitive to pain. So pain arises when the capsule is stretched. So when the liver, the kidney, or the splenic capsules are stretched, that is when the patient appreciates pain. And the pain is often described as such, as a stretching or a dull pain in that particular location within the abdomen. And again, acute pancreatitis will be discussed in detail under pancreatitis in the next series, next discussion in the series. So I'll be taking the details that will be covered there. Now, importantly, the more acute and intra-abdominal cause of abdominal pain, the more likely it is to be localized by the patient. As we've discussed, those causes where you have significant abdominal pain, but that pain is still poorly localized, we discussed, those are more chronic causes of pain where there is overlap of the sensory distributions from which the pain is arising. Okay, because of abnormalities of pain gating. Now, see, whenever we discuss a symptom, there are certain aspects of the symptom that need to be documented in history. We'll be discussing this in a detailed discussion on how to approach history taking, but basically, you need to ask the patient OPD, SR, SCAR. So that is O stands for onset, P for progression, D for duration, S for site of pain, and radiation. So if it's not a pain related symptom, then these two are not applicable. Then we have severity, we have character of pain. Now, character of pain, character of any symptom, there are, characters of individual symptoms vary depending on what is relevant for the symptom. Then we have aggravating features and we have relieving features. So I like to use this sequence and not Socrates because most importantly, the sensitivity is highest on this side of the of this spectrum. That is, there is high sensitivity. Almost every patient will tell you the onset, progression, and duration of their pain. And aggravating and relieving features are often, for some symptoms, highly specific. So the specificity is very high on this side of the spectrum. So what ends up happening is that people usually ignore this part of the history and they just take the first three sections and the last two sections. Now, this is problematic because again, we're dealing with a lot of uncertainty when we take when we analyze clinical history. So as much information as is available needs to be analyzed. And the second thing is, in certain situations, the severity, character, site, radiation, they become very, very relevant. Okay. Okay. Now coming to the discussion of how we would evaluate these five causes of abdominal pain. So as I've just discussed, these are the five causes that we'll be talking about head to head. So in case of parietal peritonitis, the onset, progression, and duration of pain will depend on where the peritonitis has occurred. So we'll talk about that subsequently. The site depends on how severe and how what is the exact location. So it is often localized but can be generalized. The radiation of pain, parietal peritoneal pain, is due to activation of somatic fibers that are innervating the parietal peritoneum. So they are usually high. They do not radiate anywhere. The severity is variable again depending on the cause. It is usually an aching or stabbing pain, and the most specific thing about the pain is that it is aggravated by sudden movement. So, coughing, sneezing, sudden movements of the patient, mechanical movements of the patient in any way. Uh, you know, Classically, this is described as pain, when you just touch the bed of the patient, and that with the, just pushing the bed of the patient's bed causes itself causes severe pain to the patient. So it's something that's very specific for parietal peritoneal pain. There are no relieving factors, and actually nothing will relieve parietal peritoneal pain, and eventually will necessitate surgical correction. Now, with hollow viscous pain, because hollow viscuses are obviously they are hollow because they conduct something, either food slash bile slash urine. The pain is due to sudden obstruction due to any cause, and that pain therefore is sudden in onset. It's rarely gradual. When it is gradual, it is often painless. Okay. On the other hand, when you have acute mesenteric ischemia, uh, almost always acute mesenteric ischemia is sudden. Sometimes it is subacute, but it would be very odd to suspect acute mesenteric ischemia in a patient who's had pain for multiple days or weeks. Now, the site depends on what site of which of the hollow viscus is affected. So the site is variable. Now, in case of acute mesenteric ischemia, radiation depends on again what is the organ affected by the ischemia. Whereas in case of distension of hollow viscus, it depends on the exact organ. So that will be just coming to. The severity of pain is in case of distension of hollow viscus, it's very severe and or moderate to very severe. Whereas in case of acute mesenteric ischemia, it's often very, very severe. So the patient has pain that is at least initially out of proportion to the signs that you elicit on physical examination. So this is in clear contra distinction from as compared to what happens with peritonitis. So in case of peritonitis, the patient's symptoms are severe, but they not may not be that severe. But when you examine the patient or when you apply slight mechanical pressure over the abdomen, there is severe pain is elicited. Whereas in case of acute mesenteric ischemia, at least initially, the pain severity that the patient describes is completely out of proportion to the pain severity that you are able to elicit during a physical exam. So these are two things that allow you to, clearly distinguish between these two causes. Then, in case of distension of hollow viscus, the classically described pain is colicky because the viscus tries to get rid of the obstruction by contracting again and again. Um, However, we'll see that this is only true for the gastrointestinal tract, and colicky pain is not characteristic of biliary or ureteric origin pain. Now, acute mesenteric ischemia pain is usually diffuse. Um, Okay. And then we have aggravation, distension of hollow viscous pain. If it is the GI tract, gets aggravated with food intake. Similarly, biliary obstruction can also get aggravated with food intake. Ureteric pain is usually not aggravated by anything. Okay. So again, both situations, if the patient is kept nil per oral, that is, you stop oral feeding, the patient's pain subsides or decreases. Distension of visceral organs, the pain is always gradual, again, because it is because of distension of the capsule. Whereas in acute pancreatitis, it is usually acute. Sometimes, in both cases, the pain can be subacute and progress over a few days. But in such situations, it requires clear explanation as to why it was, why the pain was gradual. Now, obviously, there are only three visceral organs that we've discussed that get distended like this. So, if the liver is affected, the pain would be in the right upper quadrant. If the spleen is affected, the pain would be in the left upper quadrant, and if the kidneys are affected, the pain would be in the renal angle or the back. Similarly, the pain of acute pancreatitis is epigastric and radiates to the back, and this is highly specific. Now, um, when it comes to the severity of pain, distension of visceral organ pain often is moderately severe, not very severe. Often the patient will only complain about it if asked specifically. Acute pancreatitis pain is typically very significant, very prominent. The pain of distension of visceral organs is dull or sometimes described as a stretching pain, whereas the pain of acute pancreatitis is described as a boring pain, or some as if something is being pushed into the patient's abdomen. Now, again, acute pancreatitis, because when you eat food, pancreatic secretions increase, and that aggravates the pancreatitis. The pain can be aggravated with food intake. Actually, the pain can be aggravated even with the smell of food. So often the patient at least temporarily develops an aversion to food, because obviously pancreatic secretion has got a pre-oral phase also. This is something that is very clear. Now, the relationship of food intake to aggravation of abdominal pain is something that is a lot of emphasis is placed on it in relation to differentiation between gastric ulcers and duodenal ulcers, and we'll be discussing that under peptic ulcer disease, but it is very rarely that clear cut, okay, and cut and dry. So I don't find that very clinically useful in differentiating causes of abdominal pain. I do, however, feel that when patients have an aggravation of pain with food intake, um, if it is present, it strongly indicates the presence of either a hollow viscous obstruction, particularly biliary or gastrointestinal tract, and or acute pancreatitis. Three things that you must consider if food intake is significantly aggravating the pain. Now, abdominal pain in cases of acute pancreatitis is definitely relieved by leaning forwards, and that is something that is quite specific, and something that actually overlaps with what happens with pericarditis. But usually, the pain of pericarditis is definitely retrosternal, whereas that of your acute pancreatitis is more abdominal. Now, in case of associated symptoms, parietal peritoneal inflammation obviously is, the patient is obviously having an intra-abdominal collection. So the patient has fever and has systemic inflammatory response syndrome features. Again, that is to be expected. And in case of distension of hollow viscus, the associated features depend on which hollow viscus is obstructed. So we'll talk about that. And acute mesenteric ischemia, importantly, unlike the other causes, you routinely will get diarrhea, and you will get gastrointestinal bleeding. And I'll just discuss the details of that subsequently. Now, in case of distension of visceral organs, depending on which organ is affected, if the ureters are affected, you might get hematuria and pyuria, that is passage of pus in urine. And if the liver is affected, you might get acute liver failure, or other features of hepatic dysfunction. So that is naturally to be expected. Now, in case of pancreatitis, the associated features depend on the cause, they depend on the severity, they depend on a lot of things. So we'll be discussing that as separately under pancreatitis. Now, I would like to highlight the how distension of hollow viscus and acute mesenteric ischemia often have very overlapping features, but they are notably different in some important ways. So first is GI hypermobility. So like I discussed, when there is obstruction of a hollow viscous, specifically the gastrointestinal tract. The gastrointestinal tract tries to get rid of the obstruction by contracting vigorously. This is both proximal and distal to the obstruction. So you might have increased GI motility distal to the obstruction initially, and you might have increased fecal urgency, or even what the patient might describe as diarrhea, but it's not diarrhea, it's just increased fecal frequency. And that, because the frequency is increased, there's not enough time to reabsorb the water from the feces, so as a result the feces may be semi-solid to liquid. So it's not diarrhea. I've routinely seen people misrepresenting this as diarrhea. It's not diarrhea. Okay. um, Now, in case of acute mesenteric ischemia, we almost always have similarly diarrhea and fecal urgency. This is because as the gastrointestinal tract becomes ischemic, it essentially becomes the mesenteric plexus causes discharge, aberrant discharges, and as a result, there is random contraction of the gastrointestinal tract, and that causes increased motility transiently. Now, Along with this, in case of obstruction, very commonly you get vomiting, because vomiting is reverse peristalsis, and like I said, the motility is increased both distally and proximally. Proximally, it is increased in the reverse direction, so you get vomiting, and depending on where the obstruction is, a surgeon will tell you that the vomiting may be biliary or feculent. But again, the biliary or feculent nature of vomiting only tells you regarding where the obstruction is, so that is contingent on the presumption that there is an obstruction. So you must first say that there is an obstruction, GI tract obstruction. That is when there is vomiting. Okay, every cause of vomiting need not be, need not have the descriptor of biliary or feculent along with it. Now, with acute mesenteric ischemia, typically because there is ischemia, eventually the gastrointestinal tract goes into stasis. So even if there is initial increased gastrointestinal motility, very rarely will you actually get reverse peristalsis. So it's very uncommon to have vomiting. Okay. Then constipation eventually develops in all cases of both gastrointestinal obstruction as well as acute mesenteric ischemia. In obstruction, because there's an obstruction and nothing can pass through it, and the distal bowel is now completely, emptied. On the other hand, with acute mesenteric ischemia, the bowel has gone into stasis because it no longer has the enough energy supplies to contract. So in both cases, constipation develops. Now, because there is an actual obstruction in cases of GI distension of GI hollow viscus, you eventually develop obstipation, as in even gas cannot pass through. Okay, so there is no passage of stools, there is no passage of gas. Uh, but that very rarely happens with acute mesenteric ischemia. At least some passage of gas is usually there even in acute mesenteric ischemia. Now, one very important thing that I discussed just before this is that the pain of the patient, the abdominal pain, is often very, very severe and out of proportion to what you elicit clinically in case of acute mesenteric ischemia. In addition to that, longitudinal history elicited at that point will give you this very characteristic progression in some cases, not all. So when there is this characteristic progression, you must strongly suspect acute mesenteric ischemia. And interestingly, if you suspect acute mesenteric ischemia, the probability of the radiologist or even yourself finding, the appropriate findings on imaging increases significantly. So that is something that you must suspect. Okay. Now there are some caveats that we need to discuss regarding evaluation of significant localized abdominal pain. So the first caveat is pain in non-GIT hollow viscous obstruction, that is biliary or ureteric obstruction, is not colicky. Okay. So what do I mean by the pain not being colicky? I mean that the pain is persistent. It stays. Okay. So now in case of ureteric obstruction, the pain, depending on where the ureter is obstructed, the pain there could be a dull persistent pain in the pelvis. That happens when if the junction of the ureter with the the renal drainage trust system is affected. So you get it in the costophrenic angle. If the rest of the ureter is affected, the classic flank pain that radiates anteriorly towards the inguinal region is what the patient describes. And if it is intravesicular, that is in the portion of the ureters that is within the bladder, the pain is often suprapubic. Now, in case of biliary obstruction, the pain could be due to gallbladder distension, in which case it is a steady right upper quadrant pain that radiates to the right shoulder, the posterior thorax, and the midline anteriorly. If it is a biliary duct obstruction, then pain is usually epigastric and radiates to the right lump region. So again, these are things that you pick up if you know that it is a hollow viscous obstruction. Okay, so the other features of hollow viscous obstruction should be there before you start describing these features of viscous pain. Okay, of pain, and giving them a lot of value while evaluating patients. Now, in cases of parietal peritoneal inflammation, the rate of progression of pain is variable and depends on two factors. It depends on, so the pain could be abrupt onset, rapidly progressive within one day, or it could be subacute onset, slowly progressive over 2 to 3 days. Now, it is abrupt onset when the material that is causing the peritoneal inflammation is highly, abrasive or highly chemically active and causes direct digestion of the peritoneum. That happens with pancreatic secretions and with gastric secretion. Pancreatic secretions is having a lot of enzymatic activity, and gastric secretions obviously being very acidic. Whereas if it is any other type of secretion, for example, if there is um, a loss in the integrity of the gastrointestinal tract, and release of gastrointestinal flora into the abdomen, it takes time for the bacteria to proliferate and cause enough of a inflammation there to cause you know to cause significant clinical features. So the pain is usually subacute. Similarly, when it is biliary peritonitis, biliary secretions very rarely cause very minimal inflammation, time for the patient to progress, for the patient symptoms to progress. The site of radiation of abdominal pain depends on the exact visceral organ that is affected. So this could be above, the radiation of the pain could be above the umbilicus. So that happens in case of the stomach, because the stomach, the nerves subserving the stomach are from T6 to T9. The pain is radiated to the chest and the substernal area. In case of the liver and gallbladder, it is T7 to T9. So that it is it radiates to the tip of the shoulders, as we just discussed, or the tip of the right scapula. In case of the pancreas, it is T6 to T10. So again, it goes to the left lumbar regions, as we've just discussed. At the level of the umbilicus, it is either the small intestine, the ovaries, or the large intestine. The small intestine almost always is umbilicus. Similarly, ovary is also umbilicus, because both again are T9 to T11 respectively. And the large intestine can radiate to the hypogastric. That is because of T10 to T12. If you have ever had gas, you would be aware of how this works. Uh, Now, in case of the prostate, the radiation is often either to the scrotum or the root of the penis in patients. Uh, then, in case of renal involvement, the pain is radiates to the lumbar region, and in case of rectal involvement, it radiates to the lower half of the sacrum, or to the posterior calf and thigh. Now, this is very important in case of systemic disorders. There are two systemic disorders that cause abdominal pain that are often confused with significant localized causes of abdominal pain. And this is important to understand, because again, this gets referred to the surgeon, whereas it needs to be managed by a physician, by an internal medicine specialist. So the reason for confusion, the two disorders are acute intermittent porphyria and lead poisoning. And the reason for confusion is, with acute intermittent porphyria, often the pain is very severe and acute, uh, very diffuse or poorly localized, but because of the urgency of presentation, that is, the patient is so affected by the pain, that there's a tendency to over investigate in order to not miss out on a surgical cause. And the diagnosis is often made after the fact. Now, in case of lead poisoning, very severe pain, which is slightly less acute in onset, but it is so severe and so chronic that it distorts the patient's perception of pain, and often the patient catastrophizes the pain. So often the patient themselves ask for excessive investigation, and that is why we end up over investigating. But obviously, in these situations, one must be a little careful before asking for imaging. Uh, See, in case of acute, there are clear clinical points that tell you that this is acute intermittent porphyria or lead poisoning. One is, in case of acute intermittent porphyria, the pain is neurovisceral. That is, it is due to activation of nerve signals from the gastrointestinal tract. So it is also going to affect other nerves, so there will be other neurological symptoms. In case of lead poisoning, there is a clear blood picture. That is, the peripheral blood picture will be very clear, and it should give you, it could give you some clues regarding lead poisoning. Now, when I say there are other neurological manifestations, intermittent porphyria, what I mean is there could be neuropsychiatric problems, that the patient could have acute and altered mental status. The patient could be in delirium, or there could be overt psychosis. There could be some neuroendocrine manifestations, very specifically SIADH causing hyponatremia, and this is something that one needs to be very aware of. Finally, there could be axonal degeneration. Now, importantly, normally when we'll discuss in cases of peripheral neuropathy, when you have axonal degeneration, the longest fibers are the first affected, because they have the most amount of axons to be affected. So Because of that, there is a length dependence. That is, there is a clear involvement of the feet, the soles, and then the palms, and then the limbs are affected in a distal to proximal manner. But in case of hyponatremia, that is not the case. In case of in case of acute intermittent porphyria, even though it is an axonal degeneration, it affects the involved structures are actually proximal. So it is usually the shoulders and the upper limb that are affected more than the lower limbs. Okay. In case of lead poisoning, the peripheral blood picture shows characteristic coarse basophilic stippling, and that is what we see. So there is characteristic coarse basophilic stippling of RBCs, and there may be ring sideroblasts if present. That on routine peripheral smear examination only, the hematopathologist might themselves suggest to you that it might be lead poisoning. Okay. Now, the definitive diagnosis of acute intermittent porphyria requires you to send urinary porphobilinogen levels. Any detectable value of urinary porphobilinogen is significant. We'll be discussing the details of the metabolism of porphyrins, in multi-system genetic disorders. But some things need to be talked about right now. So, porphyrin is a porphyrin precursor. It is not a porphyrin. Okay, so it gets converted into uroporphyrin type 1 and coproporphyrin type 1 non-enzymatically, even in patients with acute intermittent porphyria, where the problem is just prior to the actual generation of porphyrin. So, because of that, you actually see there are two issues. One is that you cannot just send porphyrin levels because the porphyrin levels may be false positive, and that can actually happen with a lot of non-porphyrin related or porphyria related medical disorders as well. And also, if you send porphyrin levels, they do not measure porphyrobilinogen, so there may be actually false negative also. So one must always send urinary porphobilinogen levels, not just the porphyrin levels. Now, in case of lead poisoning, what is the diagnostic test is venous blood lead level, more than 5 microgram per deciliter. It must be done twice. Now, capillary lead levels are not reliable, and it has to be venous. And sampling methodology is very specific, so the phlebotomist needs to be aware of the fact that you are suspecting lead poisoning. So again, everything boils down to the fact that you must be suspecting it clinically. That is when you will be able to evaluate the patients properly. Now, okay. Now there are some presentations of localized abdominal pain that are very that carry a high relevance in internal medicine. So what are they? One is acute, specifically acute cholecystitis. So acute cholecystitis can be of two types. You could have routine acute cholecystitis that anybody who's worked in in an ICU setting would be aware of, and then we have vasculitis related acute acalculous cholecystitis. So acalculous obviously refers to the fact that most cholecystitis is due to gallstones, but here we don't find gallstones. So routine acalculous cholecystitis occurs in critically ill patients who are nilporal, and that causes stasis of bile within the gallbladder because it is gastrointestinal. You know, uh, the presence of food within the gastrointestinal, the duodenum, that really causes release of cholecystokinin and contraction of the gallbladder. So eventually, when there is cholecystokinin release, the gallbladder is too full and does not empty appropriately. And when it contracts, therefore the gallbladder pressures rise, and when gallbladder pressures rise, that eventually results in a loss of blood supply to the gallbladder, eventually causing gallbladder necrosis. This is managed conservatively. Now, in case of vasculitis related acalculous cholecystitis, the vasculitis is involving a medium vessel, that is a cystic artery, and typically arises from the right hepatic artery. So, when do you suspect it clinically? See, acalculous cholecystitis is suspected by the intensivist within the ICU. Critically ill patients who are nilparoral, they may or may not be in hemodynamic shock because shock would worsen gallbladder perfusion further. Um, Whereas acalculous cholecystitis secondary to vasculitis is suspected in an otherwise apparently healthy person or in a person who has other manifestations that are compatible with vasculitides. The vasculitides that can present with this are polyarthritis nodosa, ANCA vasculitis, and antigen antibody complex mediated small vessel vasculitis. But by far most common is pan polyarthritis nodosa and ANCA. Now, the definitive diagnosis in both cases would require, screening with an imaging with the imaging. If you have the suspicion of vasculitis, must do a contrast enhanced abdominal CT. But if you're suspecting routine acalculous cholecystitis, then USG is sufficient in most cases. Now, confirmatory testing for PAN particularly requires digital subtraction angiography, because normal routine CT angio usually doesn't have sufficient sensitivity to pick it up, but it can at times. Okay, especially with modern multi-detector CT scans. So because in this situation the digital subtraction angiography is not therapeutic, the if you have a strong clinical suspicion of vasculitis, or you have other clinical features that strongly suggest vasculitis, and the patient has these abdominal findings on imaging, which we'll be discussing on the in the sections on imaging in this series, um, then it is often prudent to initiate treatment and not wait for digital subtraction angiography, because that just wastes time and can cause the rupture of the gallbladder and subsequent surgical complications. Now, again, like I said, critically ill patients may just be evaluated by with an ultrasound examination if you're not suspecting vasculitis. Now, in case of any vasculitis, the first thing to send is obviously C3, C4, because ANCA vasculitis will not have hypocomplementemia, whereas the antigen antibody complex mediated vasculitides will have it. PAN also usually will have elevated C3, C4 levels. If the complement levels are normal or elevated, then serum ANCA levels need to be set, because the treatment of ANCA vasculitis is very different at present as compared to PAN. Okay, now coming to the last part of our discussion, that is dyspepsia. So dyspepsia is a type of abdominal discomfort, but it's not described usually by the patient as abdominal pain. Okay, it is described as the presence of one of four symptoms for at least more than or equal to 3 months within the last 6 months. That is early satiety, uh, postprandial epigastric discomfort, again not usually described as pain, sometimes epigastric pain, and just sometimes as persistent epigastric discomfort. The causes of secondary dyspepsia are very similar to the causes of the pain that I talked about. That is, focal or localized pain that is that radiates into the abdomen. So there could be lower esophageal or gastric involvement. There could be small intestinal involvement. There could be pancreatic involvement, and there could be involvement of the heart. Obviously, parietal peritoneal pleural involvement is not going to be confused with dyspepsia, so that is not consideration. And obviously aortic involvement will not usually mimic dyspepsia. So the pain, there will be proper tearing pain, so that is something that we will discuss in our discussion. We will talk about under the series on chest pain, but the features are very similar, but they obviously do not overlap with dyspepsia. Now, in the acute setting, mesenteric ischemia to the stomach, to the esophagus, that is the branches of the celiac artery, or branches of the superior mesenteric artery, could cause features suggestive of dyspepsia. Drug-induced gastritis, esophagitis could cause dyspepsia. Hypercalcemia and could cause dyspepsia, and infections in of the stomach, that is gastritis, as well as small intestinal, proximal small intestinal infections can have features of dyspepsia. Obviously, small intestinal infection would also have other features along with it. Now, in the chronic setting, esophageal or gastric neoplasms and endocrine disorders, and these are important to consider, that is hyperparathyroidism, hypothyroidism, and Addison's disease, can have non-specific dyspepsia features because of visceral, hypoperfusion. Now, organ failure. Okay, organ failure, specifically uremia, can have a non-specific dyspepsia type of features. Now, in case of pancreatic involvement, any cause of pancreatitis can sometimes cause, dyspepsia rather than abdominal pain if it is mild. And pancreatic carcinoma can also present with chronic dyspepsia, which often gets ignored. So, in patients with unintentional weight loss and other red flag symptoms, dyspepsia should not be ignored. Okay. Now, In case of ischemic heart disease, though uncommon, ischemic heart disease also can mimic dyspepsia. But see, if you take a detailed history and if the patient is willing to provide that history, usually they describe the pain as being more severe as compared to dyspepsia. So that it is usually, you can differentiate between the two. So all cases of dyspepsia need not be evaluated for ischemic heart disease, but in a patient with high pretest probabilities of having ischemic heart disease and recent onset, very severe dyspepsia, it is prudent to rule out ischemic heart disease. Myocarditis, pericarditis can also mimic, dyspepsia. Now, in this discussion, therefore, we've covered the following topics. We've deduced the causes of significant focal or localized abdominal pain, with or without vomiting. We've compared five main causes. We've talked about some caveats in the evaluation of focal or localized abdominal pain in internal medicine. In that, we've talked about how parietal peritoneal involvement affects pain localization within the abdomen because of where the pain is radiated. We've discussed how radiation, affects localization in these cases. We've talked about the two systemic causes, that is acute intermittent porphyria and lead poisoning, and how they can mimic focal or localized abdominal pain and therefore need evaluation by an internist. Um, we've talked about situations in cholecystitis can be the result of systemic disorders, specifically when the patient is critically ill or has vasculitis. We've understood how dyspepsia is distinct from other causes of abdominal pain, and we've deduced the possible causes of dyspepsia and enumerated the possible etiologies of dyspepsia. Now, functional dyspepsia is essentially the same symptoms if there is no primary cause identified. So that is what we've understood by the term functional. So now we've covered functional abdominal pain and we've covered functional dyspepsia. And again, before we learned that before we, uh, add the moniker of functional to any abdominal pain or dyspepsia, a lot of care has to be taken to make sure that there is no primary pathology at hand. So that brings us to the end of this introductory general approach to patients with abdominal pain with or without vomiting. In subsequent discussions in this series, we'll be talking about, initially we'll start with focal localized pain, and then we'll work our way towards diffuse causes of pain. That is the reverse of the order that I've discussed the first two videos. And this is primarily because focal causes are easier to diagnose and they have very specific imaging findings. So even if the history is not forthcoming, it is often easier to diagnose these diseases on imaging, and the radiologist or somebody, an internal medicine person who is, who knows how to analyze imaging findings, will pick it up on imaging itself. Uh, so that is the first stepping stone to evaluation of abdominal pain in general. So, as things get more complicated and mixed up, it is often important to rule out these easily diagnosable causes first. So we'll start with that, and then we'll work our way up to your poorly localized causes of abdominal pain. So thank you for watching, and I'll see you next time.